Hello everyone. Today we will be discussing hernia case. So let's start. A 55-year-old male, Bhumaiya, farmer by occupation, resident of Siddipet, illiterate, belongs to lower middle class, according to modified Kuppuswamy scale. Date of admission was 25 July 2026 and date of examination is 26 July 2026. Chief complaints: swelling in right groin since 1 month and pain over the swelling since 15 days. History of present illness: patient was apparently asymptomatic 1 month back. Then he noticed swelling in the right groin region, which was insidious in onset, gradually progressed from small size to present size. Swelling increases on walking and coughing and disappears on lying down. Patient also complained dull aching pain over the swelling from 15 days. The pain is mild to moderate in intensity, non-radiating, aggravated on walking, coughing, and relieved by rest and lying down. So negative history: there is no history of similar swelling on other side, no history of nausea, vomiting, no history of chronic cough, TB, asthma, or respiratory diseases, no history of constipation, altered bowel habits, and bloody stools. No history of dysuria, urgency, hesitancy, altered stream, burning micturition, or hematuria. No history of heavy strenuous work. No history of gurgling sound in swelling. Past history: there is no history of similar complaints in past. No history of hypertension, diabetes, coronary artery disease, TB, thyroid disorders, epilepsy, asthma, and COPD. No history of previous abdominal or groin surgeries. Personal history: diet is mixed, appetite is normal, sleep is adequate, regular bowel and bladder movements, no history of allergies. Addictions: there is history of smoking since 30 years, there is no history of consumption of alcohol. Next, family history: there is no history of similar complaints in the family. So up to here it consists of the history part. So let's now discuss the history. So first we asked the demographic details of the patient. So he's 55-year-old. So he at the age, he is in old age. So 55-year-old male. His occupation is farmer. Next, he came with chief complaints of swelling in the right groin region since 1 month, and after that there is a pain over the swelling since 15 days. So in chief complaints we will write according to the chronological order. So first he's having the swelling. So first swelling, then pain which is started 15 days back. Then history of present illness: patient was apparently asymptomatic 1 month back. Before 1 month he is not having any symptoms. Then from 1 month he is having the swelling in the right groin region, which was insidious in onset and gradually progressed from small size. Initially it was a small size, and it is some cricket ball size swelling or lemon size swelling. As swelling increases on walking, coughing, and disappears on lying down. So patient also complains dull aching pain over the swelling from 15 days. So how we will describe the pain in the terms of intensity, radiation, aggravating factors, and relieving factors of the pain. So negative history: we ruled out any other swellings on the other side, or any nausea or vomiting. In also there is any chronic cough, TB, asthma, respiratory disease. Actually we see chronic cough in TB, asthma, and respiratory diseases. Because of the chronic cough, the patient continuously coughs. It causes increase in intra-abdominal pressure. This increase in intra-abdominal pressure weakens the abdominal muscles, and because of that the content of abdomen or any omentosil or any or abdominal content may protrude outside. In this way it may precipitate the hernia. That's why we asked any chronic history of any chronic cough. Then we asked about the history of constipation, altered bowel habits, and blood in stools. So because we asked this because if there is any constipation, it also increases the intra-abdominal pressure. So in the same as the chronic cough, it increases intra-abdominal pressure. It leads to weakens the intra-abdominal muscles. So contents of the abdomen or any omentosil or enterosil may protrude outside, and it appears as hernia. So these are the precipitating factors of hernia. So we are ruling out that is there any relation with the cough or constipation here. Then we asked about the dysuria, urgency, hesitancy, altered stream, burning maturation. These all to rule out the benign prostatic hyperplasia and urethral strictures. To rule out these conditions, we asked the dysuria. Dysuria means painful or difficulty in urination or micturition. Urgency is it is described as the patient want to rush immediately to the toilet. It is known as urgency. Hesitancy means there is a urge in the patient to avoid the urine, but he find it difficult to initiate the urination or micturition. That is known as hesitancy. Then the stream normal, the stream may be weak stream, or it may be in weak stream the force of the urine flow will be reduced, and in thin or narrowed stream, we will see this in urethral strictures, and slow reduced force of the stream we will see in BPH. So thin, slow stream in BPH, thin or narrow stream in urethral strictures. Then burning micturiation or any blood in urine, that is known as hematuria. Next we will be asking about the history of heavy strenuous work. In this case also, due to lifting of the heavy loads, there may be tear in the intra-abdominal pressure. There is increase in the intra-abdominal pressure, which again leads to the protrusion of abdominal contents like enterocele or omentocele through the inguinal canal. Then it presents as a hernia. So to rule out that is there any history of heavy strenuous work, we asked it. So then we also asked about the history of gurgling sounds and swelling. To rule out that the content of the hernia, is it omentocele or enterocele. If the content is the intestine, then we will see the peristaltic movement as a gurgling sounds in the swelling. So to rule out that, we ask this gurgling sound and swelling in the history. Then we will go to again past history. There is no history of similar complaints in the past. No history of hypertension, diabetes. All this we ask generally. Then we have no history of previous abdominal groin surgeries. We ask this because if there is any previous abdominal groin surgeries like appendectomy or any previous hernias, previous any umbilical hernias, femoral hernias, these surgeries or these conditions may weakens the abdominal wall muscles. So this may lead to recurrent cause of the hernia. So to rule out that, we ask this any past history of abdominal or groin surgeries. Next, personal history. In personal history, we ask diet, appetite, sleep, bowel and bladder, any history of allergies and addictions. No history of smoking since 30 years. The history smoking causes collagen disorders. Collagen is the main thing which helps in the strength of the wall. So if due to smoking there may be decreased collagen production, and it may leads to weakens the muscle wall. So next is no history of consumption of alcohol. Then family history. There is no history of similar complaints in the family. Why is there any importance of the family history in hernia case? Yes, there is importance of family history hernia case because the collagen vascular diseases which are inherited in the families, so it may leads to weakens the wall of abdominal wall. So it may be one cause of hernia. So if there is any collagen vascular diseases in the families, so we will rule out that also in the history. So up to here there is a history part which we discussed, or what are the conditions, why we asked each and every point. I hope it is clear for you all. Next we will move to the physical examination. Okay, let's start the general physical examination. Patient consent was taken. Patient is conscious, coherent, cooperative and well oriented to time, place and person. No pallor, icterus, cyanosis, clubbing and lymphadenopathy and edema. Vitals: temperature is afebrile, Blood pressure 120 by 80 mmHg measured in right arm in sitting position. Pulse is 76 beats per minute, normal in rate, rhythm, volume and character. No radial or radiofemoral delay. Respiratory rate 16 breaths per minute. Now local examination. Patient consent was taken and examined in standing position. Patient is exposed from xiphoids to mid-thigh. Inspection. A solitary swelling in right-sided groin region, medial to inguinal ligament, extending from medial to mid-inguinal point up to root of scrotum. Size 4 into 3 centimeters. Shape oval in shape with smooth surface and well-defined margins. Skin over the swelling is normal. Swelling is expansor on coughing and reduced on lying down. Surrounding area appears normal. No visible peristalsis over swelling. Penis is situated in midline with no deviation. No scars or engorged veins. Now palpation. All inspectory findings are confirmed by palpation. No local rise of temperature. No tenderness over swelling. A solitary swelling of 4 into 3 centimeters extending from 1 centimeter above the midpoint of inguinal ligament to pubic tubercle. The swelling is soft in consistency and reducible. Not possible to get above the swelling. Next, Siemens technique. Impulse is felt on middle finger on coughing. Deep ring occlusion test. Swelling appeared on cough. Ring invagination test, and impulse is felt at the superficial inguinal ring with pulp of finger and swelling goes directly backward. External genitalia is normal by palpation. Parietal examination was not done. Then percussion. A dull note is perceived. Auscultation. No bowel sounds here. Examination of inguinal lymph nodes is normal. Then systemic examination. Examination of serious. S1, S2 heard. No murmurs. Examination of respiratory system. Normal vascular bed sounds here. No adventitious sounds. Per abdominal examination. Tone of abdominal muscles normal. No scars found over the abdomen and no any organomegaly. Next, examination of CNS. No focal neurological deficit. So provisional diagnosis. Here comes the provisional diagnosis. That it is a right, incomplete, uncomplicated, direct inguinal hernia. So, an examination part. First we started from the general physical examination. Patient is conscious, current, cooperant, well-oriented, time, place and person. Next we are asked about the pickle and vitals, which are normal. Then local examination. So patient consent was taken and examined in standing position. So patient is exposed from xiphoid up to mid-thigh. In inspection we will see the swelling, how it is in terms of site, size, shape, surface and surrounding skin. So these all the points we will see in the inspection. First, site of the swelling is right sided groin region, medial to inguinal ligament. Extension, extending from the medial to mid inguinal point to root of the scrotum. So this is the site and extension completed. Then we will write the approximate size of the swelling. So it is approximately 4 into 3 centimeters and shape is oval in shape. And the surface is smooth with well-defined margins. Then skin over the swelling is normal. Then swelling is expansile on coughing. Expansile on coughing means we will ask the patient to cough and see whether the swelling is increasing in size or it is moving outward. That is protruding outward or not. So if it happens, it is known as expansile on coughing. It is seen in reducible hernias and reduced on lying down. Reduced on lying down means the swelling disappears when the patient lies down. Then surrounding area appears normal. No visible peristalsis over the swelling. Penis is situated in midline with no deviation. Okay. No scars or engorged veins. Next we will come to palpation. All inspectory findings are confirmed by palpation. No local rise of temperature, no tenderness. Then it's the same thing, whatever we have seen in the inspection, we will confirm that in palpation with measuring and palpating the swelling. So size of the swelling we measure with the help of a measuring tape, and it comes to be 4 into 3 centimeters, and extension from the same as the 1 centimeter above the midpoint of inguinal ligament to the pubic tubercle. The swelling is soft in consistency and reducible. See, what is the difference between reducible and compressible? So in reducible, after we reduce the swelling, we need a counter force to make the swelling to reappear. But in compressibility, we doesn't need a counter force to make the swelling to reappear once we reduce. So that's the difference between reducible and compressible. So all hernias are reducible, that is, we need one counter force to make the swelling to reappear, and we doesn't need any counter force to make the swelling reappear in compressible. So all hernias are reducible, that is, here we counter force we use is cough. Next, not possible to get above the swelling. It is very important, this test is very important to differentiate between the hernia and the hydrocele. See, hydrocele is confined to the scrotum, and hernia, it extends from the abdominal inguinal canal to the scrotum. So to differentiate between these two, to differentiate between these two swellings, we will do the get above the swelling test. So once we palpate, we with the help of our index finger and thumb, we palpate the spermatic cord at the root of the scrotum. If we are able to palpate the spermatic cord, that it indicates that we are able to get above the swelling. And if we will not able to palpate the spermatic cord, we are not getting above the swelling. So it helps to differentiate between the hernia and the hydrocele. So if once we are getting above the swelling, it indicates that swelling is confined to the scrotum only. It is not coming from the inguinal canal. So if you are not getting above the swelling, that is, in case of hernia, the swelling is coming from the inguinal canal. That's why we are not able to palpate the spermatic cord here. In hydrocele, the swelling is confined to scrotum only. So that's why we can able to palpate the spermatic cord. In hernia, the swelling is coming from the inguinal canal to the scrotum. So that's why we are not able to palpate the spermatic cord. I hope it's clear to you. Next, we are going to the techniques tests. 3 main tests we will do in the hernia. Those are Siemens and deep ring and ring imagination test. Siemens technique, first it is also known as 3-finger test. We will use our 3 fingers, index, middle and ring finger. Index finger for the deep ring, and middle finger for the superficial, and ring finger for the saphenous opening. So let's see how we will perform the test. So first, make the patient lie down, reduce the hernia, and keep your make the patient to stand now, and take your 3 fingers, index, middle and ring. Index finger at the deep ring, middle finger at the superficial ring, and ring finger at the saphenous opening. Keep your 3 fingers at these 3 locations. This is here we will keep deep ring, index finger, middle finger, ring finger. So now ask the patient to cough. Now feel the impulse. If you will feel impulse at the deep ring, it indicates that it is a indirect hernia. If you are feeling impulse at the superficial ring, at middle finger, then it is a direct hernia. If you are feeling impulse at the saphenous opening, that is at the ring finger, then it is the femoral hernia. In this way, you will differentiate between the indirect, direct and femoral hernia with the help of Siemens technique or 3-finger test. Why? Next. So next we are going to deep ring occlusion test. It is the only one confirmatory test and best test to be done in hernia. So how we will perform it? First, ask the patient to lie down, reduce the hernia, keep your thumb or index finger at 1.25 centimeters above the midpoint of inguinal ligament, that is at the deep ring. When you occlude the deep ring, after that ask the patient to stand. First you ask the patient to lie down, you reduce the hernia, you located the deep ring and kept your thumb or index finger at the deep ring and ask the patient to stand, and after that you shouldn't remove your thumb finger from the deep ring. Now ask the patient to cough. If swelling doesn't appear, then it indicates that it is a indirect hernia. If it appears after cough, it indicates it is a direct hernia. So see, when you occluded the deep ring, and if the swelling appears, then it is known as direct hernia, because direct hernia comes from the posterior wall of the inguinal canal to the superficial ring and it comes outside. So when we occlude the deep ring, it doesn't affect the direct hernia to come out. So it is direct hernia. When you occlude the deep ring and it doesn't reappear, it means that this in indirect the hernia comes from the deep ring. So when you occluded it, it is not coming, it is not reappearing again. So it is known as indirect hernia. I think it's clear for you. When you occluded the deep ring, if it reappears, then it is direct. If doesn't reappear, then it is indirect. So first, I hope it is clear. After occlusion of the deep ring, if it reappears, then it is direct hernia. If it doesn't reappear after occlusion of deep ring, then it is indirect hernia. So first we will make the patient to lie down. We will locate the deep ring and we occlude the deep ring, and we ask the patient to stand, and we ask the patient to cough. If it appears, then it is direct. If swelling doesn't appear, then it is indirect. You know that why the swelling reappears even after cough when we occlude the deep ring, because indirect inguinal hernia comes from the posterior wall of the inguinal canal to the superficial ring. So even if you occlude the deep ring, it doesn't affect the appearance of the hernia in direct inguinal hernia. But in indirect inguinal hernia, if you occlude it, it doesn't come out, so it doesn't reappear. So it indicates it is an indirect inguinal hernia. Next, ring invasion. So in this case, swelling appeared on cough. What does it indicate? Swelling appeared on cough, then it is direct. This test says that it is a direct inguinal hernia. Then ring invagination test. An impulse is felt at the superficial inguinal ring with pulp of finger at the pulp of finger, and swelling goes directly backward. So in this, we will, with the help of our little finger, from the base of the scrotum to the superficial ring, we will invaginate our little finger from the base of the scrotum to the superficial ring. Then we ask the patient to cough. If we will feel the impulse at the tip of the finger, then it is direct inguinal hernia. If it is a pulp of the finger, then it is indirect inguinal hernia. It is not that much confirmatory test, but this test is mostly confusing. So many of them doesn't able to differentiate between the direct and indirect through the ring invagination test. So next, other external genitalia is normal by palpation. Parietal examination was not. Why we will do parietal examination in the hernia? To see is there any BPH, benign prostatic hyperplasia. To check it, we will do the parietal examination. Next, percussion auscultation examination. The dull note is perceived. On percussion auscultation, no bowel sounds heard. If the content is enterocele, then we will hear any bowel sounds. If in that case the intestinal movements or peristaltic movements will be heard. If it is a enterocele. Next, examination of inguinal lymph nodes is normal. So this is the local examination of the inguinal hernia. So first, what we did in inspection, we looked for the size, shape, surface, extension surrounding skin and expansal of on coughing or not. Next peristalsis or penis or any scars or engorged veins. That's it in inspection. Next we will confirm the inspective findings in palpation, and we again measure the size of the swelling with the help of a measuring tape here, and we will see the consistency, and we are not getting above the swelling or not, to differentiate between the hydrocele and the hernia. And next, in Siemens technique, we are able to differentiate between the indirect, direct and femoral hernia with the help of decreasing the occlusion test. We will differentiate between the indirect and direct. If it reappears on coughing, it is direct hernia. If it doesn't reappear on coughing, it is indirect inguinal hernia. Next, ring imagination test to differentiate between the, it is also to differentiate between the direct and indirect inguinal hernia. Next, external genitalia, parietal examination. Up to here, the palpation part is completed. Next, percussion, auscultation and examination of inguinal lymph nodes. This is the local examination of inguinal hernia case. Next, systemic examination. This is common in every case, that is CVS, S1, S2 head, no murmurs, respiratory system, normal vascular background, per abdominal examination, tone of the abdomen is normal, no scars found over the abdomen. Next, examination of CNS, no neurological focal deficits. So, provisional diagnosis. So, first in provisional diagnosis, first we should mention the site, which site the hernia is, right side, complete or incomplete. What is the difference between complete and incomplete? Complete hernia means the hernia should reach the base of the scrotum. If it is reaching from the inguinal canal to the base of the scrotum, then it is known as complete. What is it? Complete inguinal hernia. If it is not reaching the base of the scrotum, then it is known as incomplete inguinal hernia. Uncomplicated direct inguinal hernia. So in provisional diagnosis, we should mention that it is complete or incomplete, complicated or incomplete, direct or indirect, inguinal or any other femoral or umbilical any other hernia. Then in this way we should write the provisional diagnosis: site, complete or incomplete, complicated or uncomplicated, direct or indirect, inguinal or femoral or umbilical. That's it. So in this way we should write the provisional diagnosis for a hernia case. I hope you understood. See, in direct, a hernia comes from the defect in posterior wall. If there is defect in posterior wall, so from the posterior wall it is coming into the inguinal canal, then from the superficial ring, then outside. So in this way, direct hernia appears, whereas in indirect hernia it comes from the deep ring, then inguinal canal, then superficial ring, then out. So this is the difference between the direct and indirect inguinal hernia. So for the management, we mostly do surgical management. In surgical management, we have open surgery and laparoscopic surgery. In open surgery we have herniorrhaphy, herniotomy, hernioplasty. Herniorrhaphy, herniotomy, hernioplasty. It is laparoscopic. This is open surgery. Herniotomy, herniorrhaphy, hernioplasty. So you should learn the difference between the herniotomy, herniorrhaphy, hernioplasty, and the type of mesh is used and types of mesh is used in this case in hernioplasty. So hernioplasty, the surgical procedure is known as Lichtenstein tension-free hernioplasty. So in this case, we will manage the case. So the precipitating factors for the hernia in this case is the person is 55-year-old. He is old in age, so there is maybe more chances of weakening of the posterior wall of the inguinal canal. This may leads to mostly old age people we see the direct inguinal hernia because of the weakness of the posterior wall of the inguinal canal. The contents will protrude easily. So in mostly old age people we will see the direct inguinal hernia, and the occupation is farmer. Maybe there is a chance of having a strenuous labor work, or strenuous any lifting of the weights, and one is occupation and one is age. And and in inspection expensal and coughing and reduced. These are the points which are indicating us towards the direct inguinal hernia. In Siemens technique, impulse is felt on the middle finger. If as impulse is felt on the middle finger, it is a, I said it is a deep ring, superficial ring at the middle finger, and saphenous opening at the ring finger. Next, deep ring occlusion test, swelling appeared on cough. Then it is a direct ring invagination test. So in this way, we will conclude the case. I hope you understood. Thank you.